Good morning, good afternoon, and good evening to everyone. We're going to go ahead and get started. Thank you all for joining our discussion today covering evidence, experience, and resources for the introduction of subcutaneous DMPA. I'm Caitlin Christensen, Project Director for a new effort called the Subcutaneous DMPA Access Collaborative, which is seeking to expand contraceptive choice by supporting introduction and scale-up of subcutaneous DMPA. I'll be moderating today's discussion, and I'm joined by several colleagues. First, Siri Woods, Country Planning Manager for Subcutaneous DMPA at PATH. Siri will provide participants with an overview of several recently released tools and resources that are intended to help support effective planning for subcutaneous DMPA introduction and scale. Next will be Alan Namagembe, Research Scientist at PATH based in Uganda. Alan will share information about self-injection, including pointing participants to key training resources and sharing some insights to date from work in Uganda. And finally, we'll be joined by Jane Feinberg, Senior Technical Advisor at JSI. Jane will be reviewing best practices for estimating commodity needs when introducing new products, as illustrated in JSI's Quantification of Health Commodities Subcutaneous DMPA Companion Guide. So in today's webinar, we'll be collecting questions and we'll plan to address them during a Q&A session following all of the presentations. If you have questions for any of the presenters today, please send them using the chat feature on your computer. We will be making slides available after the webinar today online. Before we dive into looking at some of these resources, I'd like to start with some brief background on subcutaneous DMPA. Subcutaneous DMPA is a new progestin-only injectable contraceptive that is administered under the skin. It is delivered every 3 months and is highly effective at preventing pregnancy when delivered correctly and on time. It comes ready to administer in a pre-filled device, which you see shown on the slide here. Cyanopress, which is manufactured by Pfizer, is the subcutaneous DMPA product that's most widely available today. Subcutaneous DMPA is comparable to intramuscular DMPA, which is often commonly known as Depo-Provera or other generic forms, in terms of both efficacy and side effects. The slide shown here outlines some of the key differences between the two. So for example, intramuscular DMPA is injected into the muscle, while subcutaneous DMPA is injected under the skin. Intramuscular DMPA is packaged in a vial with a separate syringe, and subcutaneous DMPA is in an all-in-one package. Because it is administered under the skin, subcutaneous DMPA is ideal for use by community health workers who can administer the contraceptive in villages or in homes. It also offers a new opportunity for women to self-inject. Cyanopress has received regulatory approval in more than 25 countries as well as the European Union. Currently, Cyanopress is the only subcutaneous DMPA product available in most countries. It has also been registered for self-injection in a number of countries and is currently available in more than 15 FP 2020 countries. Due to a recent price reduction, the product is now available for 85 cents to qualified procurers, which includes Ministries of Health in FP 2020 countries and UNFPA. This slide shown here illustrates the number of countries where introduction of subcutaneous DMPA is underway. This information is current as of May 2017. The Access Collaborative will continue to update this information on a periodic basis. Most of the evidence that has been collected to date is specific to Pfizer's Cyanopress. We do have data from multiple countries, including Burkina Faso, Niger, Nigeria, Senegal, and Uganda, that suggests that subcutaneous DMPA is highly acceptable to women and that it can also reach new users of family planning. Additional studies from Uganda and Senegal on self-injection confirm that women can self-inject subcutaneous DMPA with training and support, and that women also consider self-injection to be acceptable. Several countries, including Bangladesh, Nigeria, and Senegal, have successfully introduced subcutaneous DMPA through pharmacies, through drug shops, and other social marketing efforts. Now I'll say a few words about the new Subcutaneous DMPA Access Collaborative. The Access Collaborative, implemented by PATH and JSI, is intended to increase women and girls' contraceptive choices and empowerment by making a contribution to ensuring a long-term sustainable availability of subcutaneous DMPA as part of a broader contraceptive method mix. Funding for this three-year effort has been generously provided by the Bill and Melinda Gates Foundation and the Children's Investment Fund Foundation, or CIF. The Access Collaborative is primarily a coordination and technical assistance effort, which hopes to do two things. First is working in support of ministries of health, as well as in collaboration with country partners who are also supporting the Ministry of Health, to prepare ministry-led, total market, costed introduction plans. It will also assist in coordinating the implementation of those national plans, in tracking progress of implementation, and supporting virtual and in-person learning and information sharing, both between global, regional, and national levels, as well as country-to-country peer learning, and then provide as-needed technical assistance. The Access Collaborative will also coordinate closely with donors and other global stakeholders to be sure that global efforts are well aligned to the needs that are being expressed by countries. You'll see here that Access Collaborative is intended to support 8 to 12 priority countries over 3 years in integrating subcutaneous DMPA into their family planning programs and systems. This map illustrates the countries in which we will work in the first year of the project. Additional countries will be added in subsequent years, and the type and level of support required in each setting will vary. We'll work closely in partnership with ministries and partners to determine the needs. Additional countries beyond the 8 to 12 priority will be supported via regional technical assistance hub, as well as virtual learning and action networks. So before we turn over to Siri, here on this slide you'll see some points of contact for questions you may have. If you have questions specifically about registration or procurement, please be in touch with the points of contact noted here. Any other questions that you don't have the opportunity to ask during the webinar today can be sent via cyanapress@path.org. And again, we'll be posting this slide deck, so this information will be available to you online. I'll now turn things over to Siri Woods. As a reminder, please use the chat feature on your computer to submit questions at any time, which we'll address during the Q&A session at the end of the webinar. Siri?
Great. Thank you very much, Caitlin. Good day or good evening to everyone. My name is Siri Wood. I'm based at the PATH office in Seattle, Washington. I'm going to cover about 4 or 5 key resources that our team has identified that would be valuable to in-country program planners and implementers. The first one, next slide please. The first one is called How to Introduce and Scale Up Subcutaneous DMPA. And this is an end-to-end planning guide that has modular sections that go into topics such as stakeholder engagement and coordination, planning the country introduction strategy, product registration, quantification and procurement, training providers, generating demand, supply chain management, monitoring and evaluation, and moving to scale. So it can be used in each individual section as a resource on those topics, or it can be used as a full resource as an end-to-end planning tool. It's not really designed to help countries that have not yet made the decision about whether or not to introduce DMPA SC. So it doesn't really cover the decision-making process. It's rather designed for countries that have already made that decision and are looking for recommendations, practical suggestions, lessons learned from the past pilots, and suggestions for how to move forward through the introduction and scale-up process. The guide is about 107 pages, so it is a robust document, and it's available in English and French. It was first published about 9 months ago, and we're already working on some minor revisions, so you'll see a new version online within about a month. Next slide. The second resource I'd like to draw your attention to that is also available online is the Advocacy Pack for Subcutaneous DMPA. And this is a set of tools for advocacy and communication to increase access to and awareness of subcutaneous DMPA. The materials, you'll notice, are customizable. They are not branded to any one organization, and they're made so that any group or country can pick them up and modify them for the needs in that given country setting. And the materials were developed in concert with a number of collaborating agencies, including PATH and Advanced Family Planning. And they were heavily pre-tested at the AFP-led meeting in Dakar in January 2017. That meeting focused on advocacy for DMPA-SC. And then we worked together to revise, significantly revise this set of materials. And so what you're seeing online has taken into account a lot of feedback from stakeholders in country settings. And the pack includes a concise overview of DMPA-SC, tools and guides for assessing a country's stage of readiness for introduction or scale-up, important policies, key actions for advocates, communications and media planning tools, and handouts for decision makers. It has a wealth of evidence base and points to a lot of the research that's been done on this topic. And I believe all of the materials are available in both English and French, and we're working on a Portuguese translation. Is that correct? Great, and the link to find this whole advocacy pack, this series of materials, is on the screen. Next slide, please. The third resource I'd like to point your attention to is a communications guide to support the introduction and scale-up of DMPA-SC. And this guide is about 55 pages long. It provides an overview of considerations and recommendations for program implementers in regards to generating demand for the product in the context of informed choice. In addition to suggesting strategies, messages, and communication channels, the document highlights the evidence base related to what has been most successful in family planning behavior change communications. In fact, the document was developed based on in-depth literature review on this topic, and the content directly highlights more than 100 key references, so it's a very evidence-based document. We hope that it's a practical guide for partners that are particularly focused on communications to support demand generation and awareness raising of the product. Next slide, please. The fourth resource we'd like to point your attention to is a full set of training materials for DMPA-SC introduction. The training materials are available in both English and French and are posted online at the link that's on your screen. They include a training guide, slide sets, handouts, and job aids geared towards providers that are based at facilities, fixed facilities, as well as community-based providers. And again, this set of materials is really designed to be customizable for different country settings and training needs. They were developed as part of the pilot introduction project over the last few years, and the majority of countries working to introduce DMPA-SC have used the materials and adapted them for their local country context. So this was true in the 4 pilot countries, Senegal, Niger, Burkina Faso, and Uganda. as well as other countries such as Benin and the Democratic Republic of Congo. Generally, countries make pretty minor modifications to the guide, and that has often occurred in a workshop setting over 1 or 2 days. Last thing about this resource I want to draw your attention to is that these materials do include training, PowerPoint slides and guides related to home and self-injection of DMPA-SC, and job aids to train providers in how to supervise clients who are going to be home and self-injecting products. Next slide, please. So lastly, in the topic of tools and resources, we'd like to take a moment to review available resources on the topic of hormonal contraception and the potential risk for HIV acquisition. For decades, there has been mixed evidence on the risk of HIV infection and the use of progestogen-only injectable contraceptive products containing DMPA. Some studies suggest that women using DMPA injectable contraception might be more likely to get HIV if they're exposed. However, other studies do not show this association. In March of this year, based on a review of available evidence, the World Health Organization released new guidance on hormonal contraception and HIV for women at high risk of HIV. That guidance conveys that women at high risk of HIV can use progestin-only injectables, including products that contain DMPA-IM, intramuscular, SC, subcutaneous, or NET-N, because the advantages of these methods generally outweigh the possible increased risk of HIV acquisition. So practically speaking, WHO has shifted progestogen-only injectables from Category 1 to Category 2 for women at high risk of HIV in its medical eligibility criteria for contraceptive use. That's called MEC. And the MEC provides guidance to country policymakers and family planning program managers on developing their national policies, programs, protocols, and guidelines. So there are a few important points about the evidence on progestogen-only injectables and HIV. First, the evidence we have today is inconclusive. For example, all available data have been from observational studies. This means that data were derived from studies designed primarily to answer other questions. This type of information is hard to analyze because there are many other variables that could have influenced the results. In addition, all data to date are on DMPA intramuscular, so there are no data available on the lower dose formulation of DMPA subcutaneous, or SC. Because the products have the same safety and efficacy profile, however, the World Health Organization applies the same guidance to both types of products. And then second, additional research will provide new information on contraception and HIV. For example, a randomized clinical trial called the ECHO study is evaluating whether there's a link between use of 3 contraceptives, DMPA-IM, the levonorgestrel implant, and the copper intrauterine device, and increased risk of acquiring HIV infection. So data from the ECHO study will be available in 2019, and we may see shifts in the guidance at that time. So the bottom line is that comprehensive sexual and reproductive health programming that provides women with a full range of contraceptive options to prevent unintended pregnancy, HIV, and other sexually transmitted infections is more important now than ever, and policies and financing need to support this. We've provided on the screen 3 key documents that we think can provide you with additional information if you care to investigate further. And those are the main resources that we'd like to cover here today and make sure that people are aware of. I'm going to pass the baton on to the next speaker, and please move on to the next slide. Thank you.
Thanks very much, Siri. So Alan, we'll move over to you now.
Thank you, Siri. Good day, everyone. My name is Alan, and I'm based in Uganda. And to take us through the self-injection, specifically paying some attention to evidence from Uganda. Next slide, please. So the all-in-one presentation and the simplified injection for the DMPA subcutaneous provides for shorter training. It is easier to transport and store and less to dispose. And these unique features present opportunities to bring injectable contraception closer to where women live through community-based distribution, provision of at pharmacies and other private drug shops, and even for self-injection. And if I might say, self-injection differentiates DMPA subcutaneous from DMPA IM, which we are comparing closely because of what we've heard about the efficacy and also the mode of the operation. So Cyanopress, a Pfizer brand of DMPA subcutaneous, was approved for self-injection in the UK in 2015 and in Uganda in early 2017. And Pfizer is applying for a label change in countries like Burkina Faso, Senegal, and other countries with high unmet need, where demand for injectable contraception is high. It's also good to note that the WHO now recommends self-injection in contexts where mechanisms to provide the woman with appropriate information and training exist. Referral linkages to a healthcare provider are strong, and where monitoring and follow-up can be ensured. This is from a 2015 publication on safe abortion care and post-abortion contraception. Next slide, please. So what is the status of self-injection in Uganda? A number of activities specifically focused on self-injection of subcutaneous DMPA have taken place in Uganda in the recent years. Specifically, a past Uganda Ministry of Health feasibility study found that nearly 90% of the participants could self-inject 3 months after one-on-one training, and nearly all wanted to continue with self-injection. So based on these results, on the findings, self-injection was rolled out in late 2016 in public facilities through what we called a soft launch in one district. And the Ministry of Health actually approved this soft launch, that is self-injection outside a research setting. And we are planning to roll out in additional districts later this year in all delivery channels. These include the public sector, private sector, and channels that target adolescents. Next slide, please. So the DMPA subcutaneous self-injection training resources that are available. One key central to the training that we conduct is the client instruction job aid with visual images designed with a non-literate woman in mind to serve as a memory aid. The training and the job aid focus not only on injection technique, but also on how to store the product safely at home, how to dispose of the used Uniject device, and when to re-inject. We also use this opportunity to remind women to inject on the injectable side effects and of the need to use condoms if they're at high risk, and particularly now with the new guidelines or the revision of the MEC that Siri has just talked about. So the self-injection training materials for health workers and clients are available as part of PATH's DMPA subcutaneous training curriculum, and these include in-depth and how to support a client to successfully self-inject. Also included in that link is the client instruction job aid, which serves as both the training and memory aid for the women who want to self-inject. So we can find all those materials on that link below, which I think people can refer to when the slides are shared after this webinar. Next slide. We've held 2 webinars, and the recordings and slides provide a background on contraceptive self-injection and research results from Uganda, as well as some program implications. And these one was in June this year, designing a contraceptive self-injection program. And presenters here described how they are applying and user-centered design, principles of user-centered design, to understand how self-injection delivery would work in diverse contexts and delivery channels. And the channels are the public, private, and community-based distribution, as well as channels that target adolescents. So at this webinar, we shared some lessons learned thus far, and probably we are building on that evidence as we go along. Another is the promise to contraceptive self-injection, which we held at the beginning of this year in January. And here we presenters shared a background on contraceptive self-injection and the results from the feasibility studies on self-injection from Uganda, as well as program implications. The recordings are also available on the site at that hyperlink. Thank you. Next slide, please. So what are some of the insights to date regarding client training on self-injection? Group training may work just as well as one-on-one training by highly trained providers, although we have to pay attention to the size of the groups to maintain quality. Then careful review of the injection steps seem to be very helpful for women to self-inject independently when they are away from the provider. And as a simplified one-page instruction sheet, like one which is in the picture on the right, can help women follow through and help them correct the steps for independent self-injection. It also may be possible for women to learn to inject without actually practicing. So those are some of the insights we are learning to training women to self-inject. I'll hand over to the next presenter. Thank you for listening.
Thank you, Alan. So now we'll turn to Jane Feinberg. Jane, take it away.
Hi, everyone. Good day, good morning, good afternoon. This is Jane Feinberg from the JSI Center for Health Logistics. I'm very pleased to be able to share a resource with you where we dig into quantification of health commodities for subcutaneous DMPA, which JSI developed under another project called In Supply. Next slide, please. This guide, Quantification of Health Commodities, the DMPA-SC Companion Guide, aims to help family planning program managers, supply chain logistics managers, and procurement officers estimate and plan for commodity needs as programs introduce and integrate subcutaneous DMPA. This companion guide is about 50 pages long, and it's available in English and French at the link displayed on your screen. It's meant to be used in conjunction with a larger JSI quantification guide available on jsi.com/supply-chain. Very briefly, when we talk about quantification, what do we mean? We mean estimating national level commodity needs, ideally across sectors or channels of supply, to inform procurement of product. Quantification is made up of two main steps. forecasting and supply planning. Forecasting produces an estimate of how much product will be consumed by users in a future period. These estimates can be based on historical consumption or services data, demographic data, or estimates of services capacity. Supply planning then produces a schedule of shipment quantities sufficient to meet the estimated or forecast consumption and ensure the whole country product pipeline is adequately stocked until the next shipment arrives. Next slide, please. In this guide, we're focused on the challenge of estimating product needs. There are a lot of moving parts that make it difficult in this context. Uncertainty creates supply chain challenges for new products, especially aligning supply and demand. I mentioned we usually base estimates or forecasts of demand on historical consumption or services data or on demographic data. But for new products like DMPA-SC, there may not be historical consumption or services data, and the product may not have been asked about in prior demographic surveys. In addition, logistics management and health management information systems or forms may not yet capture the product. Programs may have expansion plans, but little real idea of future new product uptake. Training providers can be costly. Registration processes can be lengthy or unpredictable, and the effect of introducing the new product on use of other contraceptive methods is expected or likely, but the magnitude and timing of this are unknown. Next slide, please. So what's in this guide to help us try to manage and figure out what commodity needs may be in this uncertain context? The guide includes a review of key terms in quantification and how to prepare and plan for a quantification exercise. It includes a discussion of subcutaneous DMPA characteristics and offering strategies and related forecasting considerations. It includes a substantial section describing different types of data for forecasting, potential sources of these data, and sources of evidence for assumptions building, and it includes forecasting examples for subcutaneous DMPA. We also touch on estimating needs for training units, which, as we heard from Alan, is a dynamic field we're learning more about what quantities of product are needed to train providers and to train potential self-injectors. The guide also includes thoughts on supply planning for subcutaneous DMPA and a section on the importance of monitoring, which is especially crucial in the new product introduction context. It also includes references to some other useful resources. I'll just mention a few of our key suggestions for how to try and mitigate the challenge of aligning supply and demand in the subcutaneous DMPA introduction context. Next slide, please. One of our key recommendations is to develop a clear and realistic introduction plan as a prerequisite for quantification. This means defining and funding politically supported introduction strategies before undertaking provider training, quantification, or procurement of subcutaneous DMPA. The introduction plan is crucial because it helps guide some of the key assumptions a quantification team will need to make as it's generating estimates. For example, around when providers are expected to be trained and ready to offer subcutaneous DMPA, in what geographies, and at what levels of the health system. Next slide, please. Another suggestion is to integrate subcutaneous DMPA into quantification for other family planning products across sectors or supply channels. This means DMPA-SC should be included in quantification exercises with other contraceptives, even if it's only being introduced in limited geography initially. Next slide, please. Finally, it's important to monitor and update the forecast and supply plan routinely, examining whether the information on the basis of which different assumptions were made still holds true. the many uncertainties introduce risk of over or understock of commodities. To mitigate risk, monitoring needs to happen more often than usual, adjusting the forecast and supply plan based on introduction plan progress or changes or new data on actual consumption and shipments, for example. Also, because of the likely close relationship between subcutaneous DMPA and intramuscular DMPA use, joint monitoring of DMPA-SC and DMPA-IM supply plans can reduce unwanted surprises. Ultimately, it's important that program managers and supply chain managers collaborate purposefully to strengthen coordination and information sharing, since changes to supply plans affect programs and changes to program plans affect supply needs. That's it for me. I hope you'll access and use this guide, and I'm happy to answer any questions during the Q&A.
Thanks so much to Siri, Alan, and Jane. And thanks to all of you who've sent in your questions. I can see there are a number of them to answer. Unfortunately, we won't be able to address every question because there are numerous, but we'll do our best to respond to as many as we can. So the first question that I'd like to respond to is, what exactly is the efficacy of this method of contraception? So subcutaneous DMPA is 99% effective at preventing unintended pregnancy when given correctly and when given on time every 3 months. The next question is to Siri. So Siri, the question we have from one of our participants is, where and how does one start involving other countries on this initiative, particularly countries that are not in the current engagement plan but where there may be potential?
Great, thank you, Caitlin. There are a couple ways that countries that are not slated as priority countries for the DMPA-SC Access Collaborative to get some assistance and advice and recommendations and technical support. So the countries that are selected were displayed on an earlier slide. And countries that are not in that group can still tap into all of the resources that we have shared in the slides we've just presented that are online. A lot of them reflect lessons learned from the last 4 years of piloting the product in country settings with very strong monitoring systems and operations research going on. So those countries will benefit from all of those learnings. The DMPA-SC Access Collaborative will also have learning and action networks, LANs, set up for Francophone and Anglophone Africa. And so those will likely be run out of Senegal and Uganda, respectively. And they will be a virtual network of support for all kinds of stakeholders, whether they be from NGO, private sector, ministries of health, countries all over the world that have questions, that want to engage in exchange with other countries that are moving forward in the introduction and scale-up process, that have piloted home and self-injection, that want to attend webinars like these to receive specific evidence that has already been generated through prior research, and to highlight any specialized technical assistance needs that may really help them jump forward, be a catalyst for action in their countries. And so the LAN networks will have a community manager based in those 2 countries, but they'll be overseeing communications across dozens of countries. And so I would recommend that any country that's interested in more information, as soon as these LAN learning and action networks get set up in the coming months, that the countries tap into that as a resource. We will have a regional technical advisor based in Francophone Africa and probably in East Africa as well for the Anglophone world. And those individuals may be able to provide, again, targeted remote technical assistance by pointing countries to, again, specific resources, helping them remotely, walking them through the process of the introduction planning, what goes into an introduction plan, or how best to use the advocacy kit materials, those types of things. Caitlin, do you want to add anything to this that occurs to you?
I think that's great. Thank you, Siri. So our next question is for Alan. Alan, our question is there any evidence already that exists around the quality of counseling for first-time self-injection users and continued use, or is this still a work in progress?
Yeah, I'll say from the studies, we have that evidence. One, the study nurses who are counseling women one-on-one, and the competence, which would reflect the quality of counseling, we've already said it was over 90%. Although we also have some learnings from the soft launch, but we couldn't have any women's perception about the quality of counseling in the soft launch. But for the research, the perception from women were satisfied, great majority were satisfied with the quality of counseling they were receiving. But that said, is when we are rolling it out and start applying the user-centered design, this is the counseling that is kind of going to which is taking the group approach. So it's not a one-on-one because of the health workload and also the number of health workers available to do this. So from our learnings, and this is something we are continuously learning, but at least for the research, it was one-on-one and yielded very good results as per the competence levels. Thank you.
Thank you, Alan. Jane, our next question will come to you about the work in Kenya. So the question is, what is the mandate for the Access Collaborative in Kenya around Cyanopress implementation? And is there an intention to work in collaboration with other stakeholders such as GFI Kenya, which has been conducting a Cyanopress pilot under funding from the Bill and Melinda Gates Foundation? Before you respond to that, I would just note that in all countries where the Access Collaborative will work, we intend to work closely with existing partners. So we would see a community of stakeholders, including the Ministry of Health, but also including implementing partners, private sector, other key stakeholders that would form part of a network within a country to support new costed total market implementation plans. Jane, do you want to respond specifically about the experience and plans in Kenya?
Sure. Thanks, Caitlin, and thanks for the question. JFI is the lead organization under the Access Collaborative in Kenya, which means we're providing coordination and facilitation support to all of the partners, as Caitlin mentioned, and those partners include PATH and include GFI Kenya for sure. Of course, the Ministry of Health and a number of other partners who either have existing mandate and activities related to family planning or subcutaneous DMPA in particular, or related areas that need to be considered in a successful introduction. For example, information systems and how information about new products is captured or needs to be added to existing information systems in order to be captured. So just to underscore, the project in all of the countries where we'll work will be working with the sort of constellation of Ministry of Health and partners in each country, and that includes Kenya.
Thanks very much, Jane. So I think we have time for at least one more round of questions. First, just want to note that we've received a number of questions about product safety, about potential side effects. So on the question of potential side effects for this method, we would note that some women do experience some side effects, and those might include menstrual bleeding irregularities, headaches, weight gain, potential for injection site reactions, including mild pain or inflammation. In terms of product safety, the experience to date in introduction and research is that the product has been proven to be safe and, in fact, quite similar to intramuscular DMPA, which does have decades of experience behind it in study. I would also note that Pfizer will be hosting a webinar soon. I believe that's in the next 2 weeks, and we'll be happy to share more information about that with participants of this webinar. Let me also respond. We received a number of questions regarding HIV risk, and so I have a two-part question. The first part is, how are we screening women for HIV risk, especially in high prevalence areas? And then on top of that, what are we telling women in high risk areas about the fact that using cyanopress or subcutaneous DMPA may increase their risk? Because some women should be cautioned to consider other methods because of risk and not just for condoms. So probably important to start by noting that all of PATH and then subsequently through the Access Collaborative PATH and JSI's activities around introduction, scale-up, and research with subcutaneous DMPA are implemented collaboratively with ministries of health in the countries where we work. We are actively working with those ministries as well as with other partners in country who have ongoing programs in high prevalence areas on how to effectively screen women for HIV risk, as well as how to equip women with clear information that can enable them to protect themselves from both HIV as well as unintended pregnancy. Later this year, WHO intends to release updated language and guidance in their family planning handbook on how to counsel women around this potential risk. At that time, PATH will continue to work with countries to assess how to best integrate this language in ongoing provider training and service provision. As we work with countries on developing introduction and scale-up plans, this will be a key component in the inclusion of training on this aspect for health workers. So let me turn to Siri for another question. Siri, this is a three-part question about the communication guide. So the first part is the communication guide available in French? The second part is, does the communication guide include guidance on how to develop effective IEC material on DMPA? And then the third is the potential for HIV risk addressed within the communication guide? Siri, over to you.
Great, thank you, Caitlin, and thank you for those questions. The communication guide is available online at the PATH website in French. And so the link to that specific spot online is going to be included in the slides that we'll post following this webinar. And the communication guide does include guidance on how to develop effective IEC materials, including sample communications materials, some considerations for targeting different audiences, including men as a secondary audience and providers as well as clients. And then the issue of HIV is addressed at a number of points in the guidance document in a general manner. So it's not a document that is focused on HIV and hormonals. And so for more information about that topic, you need to go to those fact sheets that we listed on the slide that's related specifically to that topic that I covered. And again, those links are primarily the World Health Organization website is a great place to start. But those web links will be included in these webinar slides that we'll post online. So the communications guide really talks about HIV in passing, if you will, and in the context of informed choice and examples of dual protection messages for clients who may be considered at high risk for HIV acquisition. Does that get to the answer of that question, Caitlin?
That's great. Thank you, Siri.
You're welcome.
So next I'll turn to Alan. Alan, we have another multi-part question for you around self-injection. So I'll let you know all the parts of this question and then you can respond. So first is, in training for self-injection, what is the ideal recommended group size and duration of training? The second part is how many doses of subcutaneous DMPA are provided to each client when the client is in touch with health providers to collect a resupply. And then the third is, what have been the counseling messages used with women regarding how to store or keep subcutaneous DMPA at home?
Thank you. So for the training, like we said, now that we are considering group training, it's no more than 10 women. So, and the length of training, before it should be long, but we don't, I think it really depends on the client or the clients before you, but it shouldn't be more than an hour. And no one would give you more than an hour given the workload. Then for the doses, our recommendation is 2, and this is because we are working really with the stakeholders, including Ministry of Health. So after initial stock, after the training, 2 doses, and thereafter you can increase it to 3. Then the counseling messages on storage and disposal, really it's room temperature, away from direct sunlight, heat, water, and children, and anyone, because we know these can also cause domestic violence. Anyone you don't want it to discover that you have the product with you. Then for disposal, immediately after use, store in a puncture-proof container with a cover and close. Same, no, away from anyone you wouldn't want it seen. And then when you have the time, take it back to either the facility or a community health worker or private clinic near you at your opportune moment. And those are the key messages. Thank you.
Thank you, Alan. I wanted to make an addition to Siri's comments, just also noting that HC3 has some good communication resources available on HIV and progestin-only injectable contraceptives. So it's another resource available. Let me turn to Jane for our next question. So Jane, the question we have for you is, how are programs handling projections and supply chain around having both subcutaneous DMPA and intramuscular DMPA available in a given country?
Thanks, Caitlin. So that's a great question. And there certainly are countries managing both products. I believe all 4 of the pilot introduction countries manage both intramuscular and subcutaneous DMPA. And so in terms of estimates, in terms of forecasting, what we've recommended, and this is detailed in the guide with examples and example spreadsheets and graphs and things, but what we've recommended in the guide is to look at carrying out forecasts for all 3-month injectables and then determining with the multi-stakeholder quantification team an assumption about the proportion of those expected to be either intramuscular or subcutaneous. And of course, this is informed by progress of introduction and the geographies in which the new product is being introduced and the providers ready to offer the new product. So those things all play into this assumption about what proportion of total 3-month injectables projections would be intramuscular or subcutaneous DMPA. But that's the recommendation that we've made so far. And that's because we're just now amassing some experience doing this, right? And so as more and more countries are carrying out quantification, introducing the product, generating actual data on uptake, we'll have even better information to inform some of these assumptions.
Thanks very much, Jane. So I think one more question perhaps. So one of the questions that came in was, what is the key difference between intramuscular DMPA and subcutaneous DMPA? So in addition to that, different packaging and different delivery of under the skin instead of into the muscle, self-injection is one of the key differentiate factors. Some of you may have seen recent information from SHI 360, a study that they've conducted showing that continuation rates are higher for women who self-inject as compared to provider-initiated injections in Malawi, which does indicate that self-injected contraception can truly be a game changer, especially when it comes to addressing the challenge of high contraception discontinuation rates. And we will see more results from additional countries forthcoming. With that, I see that we have reached the end of our time. So let me first thank our speakers for your thoughtful presentations as well as thoughtful responses to the questions. I'd like to thank all of you who submitted questions and for joining us today. I'm sorry that we couldn't get to all of your questions, but a couple of potential follow-up actions for you. One is that you can visit our website. You'll see the link here. The second is that you can email us at cyanapress@path.org with any questions that weren't answered today. And then as noted, we will be sharing this presentation following the chat today. Again, thank you all for joining, and I'll wish you a good day. Thank you.